Magda De La Torre. I'm very excited to be here. We have a wonderful presentation and case for you today, and so we look forward to a very vibrant discussion. We are very excited for this opportunity to have an interactive peer-to-peer oral health community network. For those of you who are new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions usually begin with a didactic presentation followed by a de-identified case presentation. And we have group discussion that fosters really deep knowledge and builds individual capacity. As you can see, we have chatted the pre-session questionnaire, and we really appreciate your response to this. This helps us to keep improving. We really deeply appreciate just taking the time to do that. We will also chat out at the end of the session a post-session link, and that will also enable us to keep improving and to get your feedback. We really appreciate that. Just a few ECHO IT reminders just before we begin the session. As always, please stay muted unless you are speaking. You can use *6 on your phone if you've called in, or the microphone icon on the bottom left of your screen if you've joined on the computer. You can also communicate with a chat feature. Please remember that no personal health information is allowed when discussing the cases and scenarios. We are recording these sessions, and we will make them available after the session. Please note that your name does not appear in the video, nor does anything that you list in the chat. We always encourage you to join by video for the discussion portion, but if you choose not to do that, we're still happy that you're here regardless of how you join. Let's move on to a few introductions. Today we have a few familiar faces here. I'm going to start with Dr. Diogenes. If you could unmute and introduce yourself to our community.
Hello, everyone. Thanks for joining. Thanks for choosing to spend this time with me during lunchtime. So my name is Anibal Diogenes. I'm a professor in the Department of Endodontics. As you can tell, perhaps by the ad flyer, I have a DDS and a PhD. I have a PhD in pharmacology, it's neuropharmacology, trained. I'm an endodontist, practicing endodontist. So I hope today to present a content to you that comes from both basic clinical research, but also based on what I do on a daily basis in the clinic. So these are a truly translational presentation, and I hope you get some learning points out of it. That's my hope.
Thank you so much, and welcome again, Dr. Diogenes. We appreciate it. Dr. Challa.
Welcome to everyone, and thank you all for spending your time with us. And I'm Suman Challa, Associate Dean for Advanced Education at UT Health. And with the support of HRSA and all the partners here, we're delighted to program this, and hope you learn from Dr. Diogenes. Thank you.
Dr. Aguilar.
Hi, good afternoon. I'm Dr. Rosalie Aguilar. I'm part of the DENT ECHO network, and I'm one of the co-directors of this wonderful hub. I'm so glad that you all have joined us today, and look forward to a great discussion and learning today.
Thank you so much. Ms. De La Torre.
Hi, everybody. Welcome once again. We're really happy you're here. I think this will be a very informative session. I'm on faculty in the dental school as well, and part of the hub team for the DENT ECHO sessions that we bring to you every 2 months. Thank you.
Thank you so much. If you selected that you would like to receive the continuing edits education credits in your registration, we will follow up by email with instructions for completing the post-session evaluation and attaining your credits. As mentioned before, ECHO is an all-teach, all-learn supportive model, and ECHOs thrive on interaction from the full learning network. So we really encourage your participation in the conversation today. If you are shy and do not want to unmute, fear not. The chat is there, and both Ms. De La Torre and myself will be able to read questions. We also would encourage you to unmute and read them out for yourself, but if not, don't fear. Our session today includes a didactic presentation from Dr. Diogenes, as mentioned, on anesthesia and analgesia in the dental practice. In the spirit of all teach, all learn, we encourage all of you to feel free to share your experiences, your questions, and your perspectives as well. If Dr. Diogenes, if you're ready, go ahead and take it away. Thank you.
Thank you. Okay, so I hope you can see the full screen ahead of you.
Absolutely.
Perfect. So let's go right into it. Make sure. There you go. So first, let's talk about why anesthesia fails sometimes. These are the main reasons I could come up with. One is inaccurate diagnosis. It's obvious. If you're not dealing with an odontogenic pain, but you think it is, for example, referred pain pattern, and you are anesthetizing the dental structures, of course, that's not going to take care of the pain itself. There is also altered anesthetic solution issues. I want you to be aware of this because sometimes we take this for granted. You know, when you have a lot of failed anesthesia cases in your hands, you probably want to investigate what kind of solution you have. You have expired solutions, or you have a solution that already came adulterated. We had a situation like this one time in our program. We had several failures, and then I backtracked the lot number from that particular local anesthetic. And it turns out that the truck that was bringing an anesthetic here to San Antonio got stuck in El Paso in the middle of the summer. So the solutions got corrupted basically because they're in the heat. Anatomical location of the injection, of course. Unrealistic expectations of anesthesia onset. That's a huge one. I see this very often as being a problem. Patients get anesthetized or injected, and then providers want to start the procedure right away. There's a time component to this. Procedure requirements are very important. Are we doing restorative, or are we doing endo, or are we doing an extraction? Different restorative or different procedures require different depth of anesthesia. So the local tissue pH is a big one because there's ionic trapping that we're going to talk about it, and some very important neurophysiological changes that occur due to inflammation. The route of administration is a big one. Of course, if you're doing an IA block to do a case like you see here of a mandibular molar that has a diagnosis of symptomatic irreversible Popitis, this is the very worst case scenario. This is the highest level of failures for anesthesia, is when you're dealing with a mandibular molar that has been diagnosed with symptomatic irreversible Popitis, and you have to do endodontic therapy on that tooth. That involves direct nerve manipulation, right? So you'll be stimulating those nociceptors directly with your instruments for a period of time that it's long. So let's say an hour or 45 minutes to do this treatment. That's different than doing a class 1 amalgam, right? Also, procedures done in maxillary teeth, we don't have high failure rates on those teeth. So as you can see here, for IA block of what we call a hot mandibular molar or inflamed mandibular molar, the IA block success ranges from 25% to 45%. More than half of the cases actually will fail in this scenario. Whereas if the tooth was a maxillary tooth, like the ones you see here that I treated, these are all radiographs from my patients, you're going to see that the success rate is close to 100%. So we don't struggle with maxillary teeth. The real struggle is mandibular molar with inflammation, okay? How about the onset? What is the expectation? You should expect anywhere from 8 to 12 minutes to have an onset. So right after the block is given, you're going to have to wait. That onset is a little quicker for Lidocaine or Septocaine, but it's still in the neighborhood of 7.5 minutes. So it's time to inject, go drink a cup of coffee, and come back. That's when your patient will be ready to actually start a procedure. Or if you have a whole lot of talking and verbal instructions, that's the time that you'll also do this. You can explain what's coming. Rubber dam is going to be placed and this and that. If you need suction, or if it's an extraction, you can give instructions. But that's a time that it's precious. And we all are clinicians, we are providers, and we tend to move a little bit quicker than the drug is actually doing its job. So we need to provide an adequate time for this to happen, okay? And this was a randomized clinical trial study with 30 patients per group. No, not a huge study, but it's just looking at the onset of anesthesia. Location is important. if you didn't completely miss the location of your shot, right? So if you gave an IA block, for example, and you are in the pterygomandibular space and you really ascertain that you have in soft tissue anesthesia, right? You ask the patient, is your lip numb? Is your tongue numb? Yeah, I feel this. We're going to talk about this. It doesn't mean that the pulp will be numb, but it means that you didn't completely miss your shot. So that's a sign that you actually were in the neighborhood. So that's important, not to miss the location. That's kind of an obvious thing, right? But this is a big one. The pH of the tissue is very important. Tissues in the human body will be a 7.4 physiologic pH, unless we have, for example, an abscess. And those are extremely difficult to anesthetize. The reason is the drug will always be in an ionized and non-ionized state. When you have an abscess and the extracellular or the interstitial environment is at a lower pH, what's going to happen is that equilibrium between ionized and non-ionized is shifted to the left. And now you're going to have more of the non-ionized local anesthetic. The significance of this clinically is that the ionized cannot cross the plasma membrane. The non-ionized is the lipid soluble component. So if you don't have that, because it's everything shifted to the ionized phase, is not going to cross the plasma membrane. So those two states are very important. One, crossing, and the other one is the blockade of the sodium channel, the voltage-gated sodium channels. That's done by the ionized form. So you need the drug to be in its base form in order to cross, and then shift again inside the neuron into ionize and block the sodium channel. So what is this important to remember? While dealing with abscesses, you're going to have to block regionally, not inside the abscess itself, because then you'll be dealing with the situation that you don't have enough drug to cross and block the channel. And this is called ionic trapping. You're going to have the free base form and the cationic form. And I told you that the cationic cannot cross. You need the free base to cross. But low pH is going to shift this equation into having more of the ionized or cationic form. And here's a graph from a publication by Dr. Hargreaves and Carl Kaiser showing the amount of local anesthetic on the y-axis that is actually trapped by this phenomena. So if you have a 7.4 pH, which is physiologic, you're going to have only about 30% of the ions that are not available. So the 60% of the solution can actually cross lipid layers, right? However, if that pH drops quickly, you go from a 30% to or 60% of trapped to 100%. If you drop the pH by 100% of your drug is already trapped. So the pH of an abscess is about 5.5. It can be as low as 4.5. So don't expect any molecule to be available to actually anesthetize a patient when you are injecting into an area that is an abscess. The pH of the local anesthetics is important. All our local anesthetics in dentistry are very acidic. This is actually a published table from commercially available local anesthetics in dentistry, and you see the pH levels that come from the manufacturer. 3.3 is very acidic to 5.5 to 2.7 for Lidocaine, 5.2. There's a range, obviously. The most basic of all the local anesthetics would be mepivacaine, that it's kind of approximates a little more the physiologic pH, and that's relevant, right? Why are they so acidic? They're acidic to preserve the epinephrine in the solution. So when that's the reason, because if they're not acidic, the epinephrine will last only days and you cannot commercialize those products. And also this is very important for us dentists because mepivacaine being very more neutral, right? It's the least painful injection that you can give. because it's not acidic. So it's always great to start your injection with mepivocaine. Doesn't have epinephrine, it's not going to last very long, but it's less acidic and it hurts less when it goes in. Now, when you bring one that contains epinephrine, such as lidocaine or articaine, that is very acidic, that injection is not going to hurt as much because the patient is already numb by the mepivocaine. And the epinephrine in that is going to then vasoconstrict and keep all the anesthetic in the region. So if pH is important, how about buffering? This is a trend of, you can read about it. You know, we can buffer the local anesthetic and then the local anesthetic is going to work better. Dr. Malamed is a partner in this company. As a matter of fact, it's called On Farm, is a company in California that has this device that you can put a cartridge in there and then push sodium bicarbonate into the cartridge, and then you can buffer that solution to a more neutral pH. Why they don't come buffered, like I told you, is the epinephrine in that solution. If you buffer that, it's not going to last very long. If you protect from light and you keep at 4 degrees, you start losing potency very quickly after 4 weeks. So this is not something that a clinician should be making in the clinic and then storing and using in patients, because you're going to experience the opposite. Instead of having success, you might start seeing actually failures with your anesthesia. This was a systematic review that was done by my colleagues from UPenn, and they looked at all the randomized clinical trials that involved buffering of local anesthetics. And you're going to see here that they could only include 5 randomized double-blinded studies of a total of 560 patients, and they did find that it did increase the odds of anesthesia by over 2-fold. So it's already known that buffered anesthetics hurt less when they go in. More of the base form will be available for crossing lipid layers, which ensures a faster onset. Some of these studies, they start measuring very early, as early as 2 minutes after injection. They didn't wait those 10 minutes we talked about. So if you are really rushing for very fast onset, yeah, buffering makes a difference. Okay, so I think that's the main message that I'd like to provide with the buffering solution. If you wait and you also using different approaches, you can achieve the success rates the same way in a clinic without buffering your solutions. Be aware of the numb lip. Every time we ask our patients, hey, is your lip numb? Basically, you are asking if they can feel anything on their lip. The problem here is that the lip, that touch feeling, is mediated by A beta fibers, low threshold mechanoceptor fibers. These fibers are actually present in the dental pulp as well. A beta, A delta fibers are more superficially located in the dentinal tubules, and these are the fibers that get activated with hydrodynamic theory simulation of fluid moving up and down in the dentinal tubules. We all remember that, right, from our physiology and pharmacology classes. The problem here is that the C fibers are nociceptors. They are high threshold, are more internally positioned inside the dental pulp. So A beta fiber numbness doesn't mean C fiber numbness. Okay. Here you see a concentration response curve for lidocaine. And you have actually those response curve and have percent inhibition of the different fibers. And what you're going to see is that low concentrations of lidocaine are blocking A beta and A delta fibers earlier than C fibers. The C fiber inhibition is shifted to the right, which means clinically we need way more solutions, way more molecules of local anesthetic in order to block C fibers, the deep nociceptors. So you can do a class 1 amalgam, but perhaps you cannot do a direct pulp cap or a pulpectomy or root canal therapy. You need further anesthesia for that. because the C fibers are more resistant to begin with, okay? But it's not just difference in fibers. When you have inflammation, there is sprouting of the nerves. So you see here confocal micrograph of a dental pulp from a third molar dental pulp in the normal dental pulp on the left and the painful one on the right. What the difference you see here is the density of innervation is completely different. This is a known phenomena. Nociceptors are actually plastic in nature. They arborize and they branch out towards areas of injury. So now you're dealing with more innervation. It's like you have more targets to hit, right, with your drugs. So you need more drugs, okay? Not necessarily just inject more drugs, but make sure your drugs are reaching the target appropriately. How about the TTX sodium channels? So all local anesthetics will block voltage-gated sodium channels, but there are two sodium channels that we need to really talk about, NAV 1.8 and NAV 1.9. These are the so-called tetrodotoxin resistant channels. They're resistant to this toxin from the pufferfish, which blocks sodium channels. They also are more resistant to local anesthetics. They require more local anesthetic to be completely inhibited. The difference here is that they require fourfold more of the local anesthetic. And the problem with that is when we have Popitis or inflammation of the dental pulp, those channels increase sevenfold in the dental pulp. So now we have greater density of nerves and upregulation of sodium channels, the very kind that it's harder to numb. So we have our work cut out for us, right? More channels, and these channels not only have more, they're also sensitized. I won't go through all the details on that, but they get phosphorylated and all this stuff. And now they're actually hyperactive, okay? So basically we need to understand why our patients are actually experiencing anesthesia failure so that we can address that issue other than thinking that maybe I just missed my shot, or maybe this person is difficult. No, there are neurophysiological changes that happen with inflammation, with injury, that will lead you into the path of failure, perhaps. Let's talk about this case here. So these sessions are supposed to be case-based, and instead of giving you material and just show a case at the end, I'm going to do in between the talk. So this is the case of a 64-year-old male patient with a 5 out of 510 pain, all stimulated by cold stimulus. This patient could not drink even water that it's a little bit cooler, had to warm up his water in order to drink it. Very, very sensitive tooth. Patient reports moderate to severe pain for about 2 months. So he's having a heck of a time, right, for 2 months. After that tooth was crown prepped. Also, he had a root nick. You can see on the distal of that root, a nick with the burr that occurred during crown lengthening. Patient became excruciating in pain, you know, and he reports several episodes of anesthesia failure in the past. So this is somebody who's already telling us, I don't get numb very easily. Diagnosis for the tooth was symptomatic irreversible Popitis and symptomatic apical periodontitis. So root canal therapy was indicated. I'm going to have a question for the audience. What anesthetic agent is more effective for an inferior alveolar nerve block in a case like this? I'd like to know kind of what is the climate here. What do you think it is? You'll be Lidocaine or you'll be Articaine. You can just say A, B, C, or no difference. I'll give few seconds. It's not going to be, I don't want to run statistics on this, but I just want to see what is the overall feeling of my colleagues regarding this.
Go ahead and post your answers in the chat, learning community, and we can get a feel for the room. We're getting a lot of C's.
Mm-hmm. Yeah, I see a lot of C's and mepivocaine in there. Okay, so let's talk about this. I expect, well, mepivocaine is an interesting one because you're going to have a short onset of anesthesia, but it's not going to last very long. So by the time that you actually are doing any procedure in this patient, after the rubber dam goes on and you access and you get into there, that mepivocaine is pretty much gone. All right, it's going to last maximum 30 minutes, and then you're going to experience failures. One burning question is, I hear this all the time when I lecture about this topic, is, well, Lidocaine is my to-go anesthetic solution. It's way better than Lidocaine. And here is a meta-analysis of clinical trials looking at Lidocaine versus Lidocaine for inferior alveolar nerve block as the primary solution to block a patient with symptomatic reversible Popitis of mandibular molars. Again, I'm using the worst case scenario because if it can get those patients numb, everything else kind of follows under that umbrella. There is no statistical significance between Lidocaine and Lidocaine when used for blocks. Okay, this is study after study. You can see all the randomized clinical trials that do not fit the criteria of this meta-analysis. They will show the same trend. Okay. This one is it's another study, a meta-analysis published by now our European colleagues, showing that Lidocaine is more efficient or efficacious than Lidocaine. So what is with this discrepancy? I want to point out to you that the studies included are not only inferior alveolar nerve block. So look at the top studies here. I don't know if I can point, but the top studies, when it says any delivery route, those are maxillary teeth. And that, as an infiltration, Lidocaine is fantastic, but not as a block. The block studies have no difference. They all are touching the line of no effect on that meta-analysis, okay? So once again, consistent, even when the focus of the study is a little different, is a consistent finding. There is an issue, although controversial, that Lidocaine is more associated with cases of paresthesia, which will be continued numbness in the area of injection. It's been reported in different countries. It's not a consensus, but since it's been published, there have been several litigation cases involving Lidocaine and paresthesia. Okay, and I myself, lecturing about this topic, have met few dentists that have been sued over paresthesia cases involving the use of Lidocaine as blocks, not as infiltrations. It's the incidence is about 1 in 1.3 million. So it's rare. Although it's rare, I met 3 dentists that have been unfortunate to fall in these statistics. And since it's published, it's something that is a little hard to argue in court, right? And 94% of the cases are associated with IAN blocks. The others are mental infiltrations, okay? What is interesting about this is that 89% of all those cases involved in lingual nerve. So there is this argument that the paresthesia is not due to Lidocaine, it's the needle penetrating too deep and nicking the lingual nerve. But I'm going to assume that the needle also penetrates deep when you're giving Lidocaine. So the argument, it's kind of like that. The cases that you see here on the graph, the blue line is Prilocaine. And then when the Lidocaine came in the market in 2000, Prilocaine use pretty much tanked. And then the red line is Lidocaine. And then the cases of paresthesia shifted from a Prilocaine paresthesia to Lidocaine paresthesia. Both those solutions are 4% solutions. So maybe is related to the concentration, 2 versus 4%. By the way, Lidocaine doesn't exist as 4% because you'll be cytotoxic at that concentration. Okay, so Lidocaine in these studies, although controversial, 3.6% more associated, or excuse me, odds ratio, 3.6 times more associated with paresthesia, although not a consensus. So what is the most effective administration route of supplemental anesthesia for this case? So you already gave your block and the patient is not numb enough. So what are you going to do then? You think it could be A or B, PDL injections, or C intraosseous, a mental infiltration, or no difference? Okay. Yeah, I see a lot of good answers here. There's not a wrong answer, to tell you the truth, because these all are supplemental anesthesia routes, right? So we'll talk about efficacy, what really works and what kind of level it works. So first, let's talk about buccal infiltration. You already gave a block, you're going to do a buccal infiltration. Here are results of 2 different meta-analyses using or evaluating Lidocaine versus Lidocaine for buccal infiltration. And look at that. Lidocaine is substantially better than Lidocaine as a supplemental buccal infiltration after the block. That's where it shines. It penetrates lipid barriers really, really well. And you can, even through a cortical plate in the mandible, get supplemental anesthesia using Lidocaine, increasing the local concentration of the local anesthetic. Both meta-analyses show that. How about PDL injections are widely used? Yeah, you can increase, there's all kinds of rates reported, 63% to 92%. These are not all, the Walton study in the JADA, not all symptomatic irreversible Popitis mandibular teeth. In a mandibular molar, it raises from 25% to 56% only. So that's, to me, as an endodontist, I cannot live with that. I cannot live with 50% of my patients maybe experiencing pain. It's simply not a good approach. It's like flipping a coin and then saying, are you going to be numb enough or not, right? Not enough. So 86% experience discomfort of the injection, and 36% feel like the tooth extruded later. So what happens is you push solution under tremendous pressure into the periodontium and you damage the ligaments. And that creates an inflammation. The tooth gets raised out of the socket, now becomes a premature contact, plus you're going to have mechanical allodynia from the inflammation. Now your patient is hurting, not because of the root canal, but because of PDL injections. So that's an issue that could be there, okay? Intraosseous anesthesia is a fantastic supplemental anesthesia. We have 2 different commercial products out there, Stabident and X-Tip. I found X-Tip substantially easier to use, although I like the suggestive name Stabident. I think it's kind of cool name, but the X-Tip, it is, in my opinion, a superior system. Okay, it has a cannula, you put on a low speed handpiece, you perforate the cortical plate, a cannula stays behind, and then you can give intraosseous anesthesia very, very easily. These are 2 different randomized clinical trials in which mandibular teeth with irreversible Popitis were included. You're going to have just your IA and block, 2 cartridges. And you're going to see 19% success, extremely low in these cases, or 25%. If you're given 1 injection with 2% lidocaine, you raise that success rate to 88% with intraosseous. And if you give 1 cartridge of 3% mepivocaine, you now increase the success rate to 80%. But if you give a second cartridge, intraosseously, now you're dealing with 98% success. So if you ask me what I do for my patients with symptomatic irreversible Popitis on a mandibular tooth, I do exactly this. I give my block and I give 2 cartridges of mepivocaine via intraosseous injection. Almost 100% of all my patients with that diagnosis for those teeth receive this, including my mom and my sister. So everybody gets it. So I'm a true believer in that. And if I needed it, I will request the same for myself. What are the considerations for intraosseous? Should avoid important anatomical structures such as the mental nerve. Obviously, the inferior alveolar nerve canal, stay away from that area. Sinuses, roots, sometimes you do perforate and you hit a root, no problem. Relocate, grab a new cannula, a new perforator, go to different sites. The major thing is to be away from nerve bundles, right? We don't want to create nerve damage. Use proper technique, perforating a cortical plate, not to create overheating of the bone that could create small areas of necrosis. They tend to resolve very fast. Of course, any patients under anti-resorptive medication should not be undergoing this, right? Bisphosphonates, for example, should not use this. Other considerations, there's an immediate onset. It's absolutely in seconds, okay? But it will last only 30 minutes because you use mepivocaine. If you use lidocaine, it's gonna last longer. However, since it is a systemic injection, your patient will feel the effects of epinephrine immediately. So it needs to be somebody very healthy, somebody who's aware that the heart rate is gonna increase 21 to 28 beats per minute, and it may last 2 minutes. So you need to tell them this is going to happen, and it's not you getting nervous, it's your body reacting to the drug that I'm giving to you. It is a systemic injection, right? But I feel like this is not needed really when you use mepivocaine, but you have to act in a timely manner. If you can get the pulp debrided by 30 minutes, you'll be okay, right? So this is a video of one of my patients and had symptomatic irreversible Popitis on tooth number 31 there. And we're going to give, I already gave the block. You see the video of a small infiltration here, just infiltrating the area where the X-tip perforation is going to happen. And we're going to bring the X-tip perforator on the handpiece, low speed. You want to be in attached gingiva, right above the mucogingival junction, with a slight apical angulation to the perforator. And then you will activate the perforator and you're going to go with some tapping motions through it until it perforates. And then you're going to hold the base of the cannula and remove the perforator using the same angle that we went in. You want to be careful not to luxate this. You don't want to break anything in there. But now you have a cannula in there. And note that the speed of injection, it can be fast. It's a little faster here because the video is sped up to facilitate showing this. So what I would like to do also is to put an endodontic rubber stopper on the needle of the X-tip to serve as a gasket. So that needle is going to go in and it's going to seal really well on the cannula. And then I'll give my 2 injections of mepivocaine. And right after that, I can go in with very high certainty that the patient is numb and the patient is not going to have a surprise. I'm not going to have a surprise. So everybody's more relaxed throughout the procedure. I hear over and over again of patients saying, I've never been so numb in my life. This was great. Usually they don't complain that they're too numb when they're getting a root canal, right? They will complain if they feel anything, and then that trust kind of goes away from that room, and now you're dealing with anxiety and all things. Little bleeding in the site, no big deal. This is, you're going to remove this, and 2 days you're not going to be able to find the perforation whatsoever. This heals very, very fast. So as you can tell here, The cannula is then removed, a little bit of woozing, but not much. And then the access can be initiated and all that. Okay. So let's apply some evidence-based decision here. So the block was given. We actually gave intraosseous in this patient 2 cartridges of mepivocaine. This is the 2% that actually failed. It failed. We couldn't even clamp the tooth after that. So this was out there, right? He wasn't numb, basically. Patient became very agitated, saying, I told you, nobody can get me numb. Oh my gosh, what's gonna happen now? So what's next? Question, which adjuvant therapy could be used or be beneficial in this case? What do you think would help us go over the hump? Preemptive analgesia with NSAIDs, meaning patient comes pre-medicated, oral sedation, the triazolam, for example, nitrous oxide, or all of the above. I see lots of A's.
A lot of A's.
Yeah, lots of A's, which is good. It's good news. The answer could be A and C, kind of, but more A, I agree. So preemptive analgesia has a big rationale. Inflammatory mediators are the ones that are sensitizing those nerves, right? So if you have a lot of inflammatory mediators, how about we decrease inflammation? And we can do that with steroids or with NSAIDs, right? Here is a very large meta-analysis, very large, looking at over 17,000 patients. And you're gonna see that the line of effect favors preemptive analgesia. So if patients are pre-medicated with 600 milligrams ibuprofen, for example, 1 hour prior to your therapy, you just increased your success rate from a 30% to 60, 65. That's meaningful, okay? And supported by several randomized clinical trials. How about the effect of sublingual triazolam? What is that with the argument that, oh my gosh, I'm just nervous, right? And because I'm so nervous, the anesthetic doesn't work on me. No difference. These people took triazolam and then went through endodontic procedures and still experienced the same failure rates of the ones without triazolam. So triazolam doesn't seem to be what made the difference. It made them a little bit more relaxed. They could be napping a little bit, but the moment that they felt the pain, they felt it. They wake up and it's a rude awakening, right? It's like, oh, what was that? So doesn't help. How about nitrous oxide? Actually, it does help. You can go from the 25% for hot lower molars to about 50%. It doubles success rate. 50% is still not very impressive, right? It's 50-50, but it improved. And this improvement is significant. It's a bit curious because it has nothing to do with the level of anxiety, which was measured in this study. It has to do with the pharmacokinetics of pharmacodynamics, excuse me, of nitrous oxide. It's actually a modulator of spinal processes. So nitrous oxide modulates NMDA receptors in a spinal cord. So what does it mean? It means that it suppresses at the level of second order neuron the neurotransmitter glutamate, which will further stimulate and transduce the nociceptive signal upstairs through the spinal thalamic tract to the prefrontal cortex. So it's an agent that we use all the time in a clinic, and we can use that as an adjuvant for local anesthetic success in our clinical practice. So it's going to act right there in these NMDA receptors by suppressing them and decreasing the glutamate neurotransmitter input from primary to second order neurons, and then thus inhibiting nociceptive signals to the central nervous system. So let's put it all together here. Patient returned for continuation of treatments with pre-medication of ibuprofen, 600 milligrams. We actually started the day before, and he came pre-medicated with that. Patient did take triazolam because he chose to. Patient received nitrous oxide at 40%, and we gave the supplemental intraosseous anesthesia. And you see the cannula there on the radiograph. In this case, instead of giving 2 cartridges of mepivocaine right away, we gave 1, knowing that if we needed to extend anesthesia later, we could go back to the cannula left in place and give more in this patient. So that you see the cannula on the radiograph. And the treatment was performed uneventfully. He didn't feel anything, and was the first serious dental procedure, in his opinion, that he was fully comfortable. Of course, here's the maximum concentration for local anesthetics for the healthy individual. Obviously, if you're dealing with any cardiac situation, you're gonna have to watch epinephrine concentrations. But what I'd like to point out to you is that we're dealing or talking about 10 carpios, 11 carpios of local anesthetic. I've been an endodontist now for 15 years, and I've never given more than 5 carpios to any of my patients. Hundreds of patients that I've treated, maybe thousands. Never. Why? Because I use supplemental anesthesia. It would be wrong to keep on giving blocks when the first block already failed. You need to do supplemental anesthesia, and supplemental anesthesia doesn't use tremendous volumes. If you did, for example, buccal infiltration after your 2 cartridges of block, and you gave 2 cartridges of intraosseous, you only have not even 5 cartridges there. 10 cartridges, not necessary. If you keep on injecting, it doesn't mean you're going to eventually get somebody numb. All right, so you got to use different routes. So my recommendation for local anesthesia is first inject the solution to be 3% mepivocaine, followed by your choice of Lido or Lidocaine. Always a total of 2 carpios for endo to start with. If you're doing endo, if you're doing extraction, 1 cartridge will not be sufficient. So you want to do mepivocaine, Lido, and then ensure that your patient is numb. This is way below accepted doses, even if somebody has a cardiac condition and you just gave 1 cartridge with epinephrine. You're already limiting this. Depends on if it's controlled or uncontrolled, ASA 2, 3, right? But that's just a general guideline. For cases of symptomatic irreversible Popitis, pre-medication of 600 milligrams ibuprofen is very important. Okay, it's gonna help. Supplemental infiltration of 4% Lidocaine is buccal infiltrations. Nitrous oxide and intraosseous will be the most predictable way of achieving increased anesthesia in patients with very difficult to numb cases, okay? Let's now touch bases on analgesia. This will be quick. I'm not gonna talk about opioid epidemic. I'm gonna straight to the meat. I'm gonna go straight to how we actually should help our patients. This is a case of a 57-year-old male patient that had moderate to severe pain for 2 weeks prior to seeing me. Reports that he's unable to eat on the left side. Cold food and drinks evoke a pain that it's maximum. Patient pain was reproduced on testing of tooth number 16, 3rd molar, with symptomatic irreversible Popitis. I actually treated the 3rd molar. We don't treat wisdom teeth with endo often. Extremely challenging, especially this one that's calcified and curved. But we could do that, right? But the patient had no systemic conditions or medications. What will be the first line of analgesic for this patient, in your opinion? Should you do ibuprofen 4 times a day, or Tylenol? Or you should go Tylenol with codeine. You're now using a combination narcotic. What will be, or tramadol 3 times a day? Will be your choices. I think most of us here, especially here in the UT and UT train and all that, we're very familiar with this regimen, right?
Lots of A's in the chat,
yeah,
Dr.
you see?
Diogenes.
That's a
Yes.
good sign. It's a very good sign because, yeah, we're dealing with an inflammatory condition and you should use a non-steroidal anti-inflammatory drug to treat it, right? It makes sense.
Absolutely. And actually, we have another question in the chat with regard to articaine use in intraosseous. Is it a no-no to do that, to use articaine in intraosseous?
Yeah, there's no benefit with using articaine as intraosseous. And God forbid we end up with a paresthesia, will be devastating because it's going to involve the whole distribution of the inferior visual nerve. So I stay clear away from that because I don't see any reason for it if you're achieving 98% success with metpivocaine. That would be my opinion on that and what the evidence is showing. But yeah,
sorry,
okay,
go ahead.
No, please go ahead. Yeah,
no, I was going to ask, we're almost at the top of the hour. Are there any burning questions that you would like Dr. Diogenes to address based on what we have seen?
Yeah, so far with the anesthetic.
Please go ahead and chat them out or feel free to unmute and speak. Yeah,
if somebody has a question, we don't need to, we can just address that. I don't want anybody leaving with questions.
This has been an amazing, informative session. I'm sure there are many,
thank you,
many questions from our learning network for all the information that we have received.
No,
this is Dr. Murphy. Can you hear me?
Yes, I can hear you well. Yeah.
Thank you. I was just wondering, and thank you for your well thought out information today. Very helpful as a daily aid. I'm wondering your opinion regarding Marcaine.
Marcaine has a very slow onset and will stay there for a long time. And that's why we always use Marcaine after periapical surgeries. So if we've done an apical, for example, at the very end, we inject the patient with Marcaine. That allows them to be number for a longer period of time, and they can go home, they can medicate, they can do the local measures that we asked, ensuring just prolonged anesthesia. That's why we use Marcaine. We don't use it just for a procedural thing, like I'm doing a root canal, I'm going to do Marcaine right off the bat because the onset is very delayed.
So it's more used a little bit more for what you send the patient home with.
Correct. Prolonging anesthesia for the patients that are okay with it. We explain because that's not, some people are not okay. They don't like being numb for too long. I don't see too many of those after we do an extensive procedure. They ask for it. They're very okay. Yeah.
James Harris, would you like to unmute and ask your question as well? Thank you, Dr. Murphy, for your question.
Thank you.
I see a question here related to nerve fascicular pattern and lingual nerve paresthesia. I don't know any. That hasn't been looked at. Is an excellent question. We know that 89% is related to lingual nerve, so that's what we know. But the pattern of the nerve, and I mean, I would think that this is extremely difficult to study in patients, right? It'll be extremely difficult to study that. You can see these patterns in cadavers, but not in our patients. So it'll be difficult to get that. But it's the lingual nerve. That's where the problem actually lies. Okay.
I have a question. Thank you for that amazing lecture, Dr. Diogenes.
Thank you very much.
You showed a table with the maximum doses and all that, and the maximum carpules.
See if I can go back to that.
If the doses, well, we all know that the doses are based on patient's weight, right?
Yeah,
patient's
correct.
Weight. So those numbers in the middle, maximum recommended dosages. So Lido, it says 500 milligrams, Marcaine 90 milligrams, and so forth. Are those arbitrary numbers? Because if we're talking that
This,
we've all known that it is by weight. So you
right.
cannot apply the same to a patient who's 70 kilos to somebody who's 100 kilos or something like that. So yeah, go ahead. Are those arbitrary numbers based on safety or?
No, you see the table on the bottom there says, assuming patients of 150 pounds.
Yeah, it's like 70 kilos, yeah.
70 kilos. So that's where it is, you know. So this is calculated based on 70 kilos.
Okay. Yeah, because I've, we always in oral surgery work under the premise that it is weight-based. So
Yeah.
sometimes with patients are like 230 pounds. So
correct.
And like you said, we usually never go above 10 carpules, but when we're doing like full mouth extractions or thermolars, we need a little bit more local that you guys sometimes use. Yeah. Okay, that was my question. Thank you.
Yeah,
so
it's all related to weight. Yeah, absolutely.
Okay. All right,
absolutely.
thanks.
You're welcome. So
Aisha, sorry, go ahead, Dr. Diogenes.
No, that's fine.
I had just seen that Aisha had a question about analgesia in the chat. Aisha, would you like to unmute?
Hello.
Yeah.
Yes,
hi.
go ahead.
Yeah, I just wanted to know that which anesthetic agent shall we use will be better, Lidocaine or Articaine?
It depends. So as I shown in this talk, Articaine and Lidocaine, they're not better from each other if you're just given a block. If you are trying to anesthetize it via infiltration, Articaine will be better. Okay.
Yeah, thank you.
That will be the main thing. Yeah, you're welcome. Yeah.
Any other questions from the Learning Network as we wind down with our last few minutes? I would be interested to know, Dr. Diogenes, in your experience with anesthesia and analgesia, what has been the most challenging case that you've had? And you've had thousands, maybe there's more than one, but just pearls of wisdom from your experience here.
I included in this lecture, one of the most challenging cases that we ever seen was this case I included here. I included with a purpose of showing what's the very worst case scenario. Somebody that got an intraosseous and we couldn't put a clamp on the tooth. I had other presentations just like that. And for those people will be the combination of what we talked about. Really will be pre-medication event SADs, intraosseous or buccal infiltrations of Articaine and nitrous oxide. Those are the things that make the biggest difference when used combined, because now you hit in a different mechanisms and different sites, and you are ensuring that you can actually do treatments. We never had a patient that we couldn't perform the treatments using these approaches, and that's something to be said. Once all you do is treat pulpal disease, and if you can ensure that everybody gets the treatment they need and deserve, that's what we're here for, right?
Absolutely. I think that's such a great thing to take away as well, just that really deeper approach to understanding the anesthetic, and not just as a jab or a stab into something, but that there is significantly more behind it. Dr. Diogenes, I wonder if you would mind unsharing your screen,
Sure.
And then we can continue to take questions from the audience as well.
Absolutely.
From our Learning Network.
Yep.
It's been great so far. Thank you for your participation.
We didn't cover analgesia, but you can ask me questions about analgesia if you want to.
Well, in these last few seconds, I would like to thank you all for joining us today for this DENT ECHO, and a very special thank you for Dr. Diogenes to wearing multiple hats today as the didactic and case presenter. Thank you especially to our hub team as well for their participation, and thank you to you all for joining and making this possible. We have posted the post-session survey link in the chat. We would really appreciate your participation in that. And then we also have posted a link to the resources that are available for this ECHO as well. But thank you so much. We will look forward to seeing you on November 18 for our next DENT ECHO. Thank you so much and have a great rest of your day.
Thank you.